Good morning. I'm sorry, I have to leave, and I needed to start. Florian asked me to speak about the study we have done on the spirituality, the dignity therapy, the hope, and this is for us the complementary medicine. And so in generally in Italy, when we speak about complementary medicine, we speak about herbs, but this is a new way and an integrative way to communicate with the patient. I believe that this must be the daily practice in our activity. We created a research group on this because believe that the total suffering should be considered starting from the diagnosis, who is for us the first and the most important moment of crisis for the patient, because the patient's life changed completely from this moment until and during all the trajectory of cancer treatment. How to take care for the patients globally? First of all, we have to take time to talk with the patients. I am oncologist and pharmacologist. I know perfectly that we don't have time to do this, but this is part of the care of the patient, and together with the chemotherapy and together with any kind of supportive therapy and any kind of palliative therapy and any kind of treatment of pain. And so this is important to take time for this and to assess their needs, physical, emotional, social, spiritual, by means of validated assessment tools. Is important to validate at the national level the assessment tools. In these ways, we can link together and do and perform international research. Only in this way. In 2009, I created the first dedicated supportive care unit, I believe, not only in Italy, but I believe also in the world, because there are not dedicated supportive care unit. There was not a dedicated supportive care unit till death. And one on the aim was to create a bridge project with the oncologist practicing chemotherapy until to the end of the patients and treating all the aspects of the patients. And so the primary purpose was to support in the oncologist in implementing in all the supportive care to reduce or to prevent the toxicity of antineoplastic therapies. The second purpose was to assess the physical symptoms, to give information, communication, to study the emotional, social, spiritual needs, in addition to the necessity of search of the meaning regarding to the new dimension of life. And so this is a global care that we need to implement, because it is not possible to cure the body in a separate way from the soul. We can inform the patients. The health care provides inform the patients about diagnosis, oncological therapies, toxicity, supportive care, symptom control, palliative care, prognosis, but the patients have to inform us about their needs. And so we started with the validation of the ISAS in Italian language, because I believe that ISAS is the most simple and the most complete assessment tool that is possible to use in the daily clinical practice, because we can have data on pain, fatigue, nausea, depression, anxiety, somnolence, appetite, the sense of well-being, difficulty in breathing, and others. Two of these items, depression and anxiety, may be too much simple by means of ESAS. However, if we have to assess the emotional symptoms of our patients, we have the assessment tools very long to apply in the daily clinical practice. And so we performed a study comparing the ESAS, anxiety depression of the ESAS, with the hospital anxiety depression scale in patients, 196 patients with non-advanced cancer. Only 12% of these patients had metastasis. And we try to compare the ESAS and anxiety depression scale. There is a high sensitivity and specificity of ESAS for anxiety and also for depression. And so we can also, in a daily practice, use this kind of assessment tool as a screening tool, just as a screening tool to define if our patient need to be studied more and more for these problems. And so we can also assess the emotional problems of the patients and to call the psychologists, the psychiatrists, and to give more attention to the patients. Regarding spiritual care, we found that the literature, there is a lot of literature on this topic, because after the diagnosis of cancer, many patients find themselves involved in the search of the personal contact with the transcendent, also independently of the religious affiliation. And these spiritual issues may be important even when they are not expressed as a participation in a religious ritual or adherence to specific religious belief. We found that some assessment tools present in the international field was, regarding spiritual care, were too simple, not completed for us. And so we decided to validate in Italian language the system of belief inventory created by Jimmy Holland at the New York, the Memorial Sloan Kettering Cancer Center. We studied 257 oncological patients on active treatment, only 12% with metastasis. We confirmed the psychometric properties of this assessment tool, but why we decided to validate this assessment tool and not another assessment tool? Because this assessment tool was designed by different people, by clergy, by healthcare professionals, and by the patients. And so at the Memorial Sloan Kettering Cancer Center, these people found around the table and they created this assessment tool. It's not only the point of view of the clergy, it's not only the point of view of the oncologist, it's not only the point of view of the patients, but all together work to create an instrument to better understand the spiritual and the religious needs of the patients. And so for us, this kind of assessment tool is very simple. Moreover, it is validated also in Hebrew, German, and Spanish. And so we can do research with this kind of colleagues. But we also try to understand if the spiritual life of cancer patients is a resource to be taken into account by professional caregivers from the time of diagnosis. This is a cross-sectional studies, and the result were that 81% of the patients believe the religion to be important or very important in their daily life. 65% pray during difficult moments. 47% share their beliefs with other people groups, And unfortunately, only 15% is supported by their religious community during difficult moments. This is a point that you have to investigate very well, and we have to try to share with the people that can help us in this. How to use the resources of these patients, taking the patient's resources into consideration from the diagnosis, giving a sense in the relationship, patient's dignity, hope, the sense of meaning. For this reason, we also validated in Italian language the patient dignity inventory created by Avi Chochinov, the Hope Index, and the Purpose in Life, that is the basis of Viktor Frankl's search of meaning. And we validate all this kind of assessment tools. And in particular, we are working on the dignity therapy, that is a new way to communicate with the patient and also to practice psycho-oncology with the patient. This is the Italian version. And we found a lot of very interesting results that can help the physician to work and to can help the physician to help the patients, and can help the patients to help the physician to take care of them. In particular, the patient dignity inventory is a new model, a novel way of measuring dignity-related distress in palliative care, but it is possible to use in any moment of crisis of the patient, and is editing in a creative way the life of the patients. The patients start to speak about her life and to write about her life. And so it's produced a document that can help the patients, and this is very well documented through a narrative process, and help the physician, and help a lot the family. Because sometimes only in this way the family members can really understand the needs of their patients. And so I believe that the time is finished. I prefer to stop here, to say goodbye to next year in Copenhagen for the MASK Congress. Thank you very much.